Welcome back to the 2022 Cancer Research Institute Virtual Immunotherapy Patient Summit. During this next session, we are going to learn about the latest advances in using immunotherapy to treat prostate cancer, the leading cancer in men after lung cancer. We are joined by Dr. Larry Fong, who is the F.M. Gusick Distinguished Professor in Cancer Biology, leader of the Cancer Immunotherapy Program, and co-leader of the Cancer Immunology and Immunotherapy Program at the Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco. Brian Brewer from the Cancer Research Institute will be sharing your questions with Dr. Fong, so please be sure to put them in the Q&A box. Dr. Fong, Brian, thank you for being with us today.
Right. Thank you, Tamron, and the CRI for having me for this virtual patient summit. Prostate cancer is obviously a very common disease and one that we're really looking forward to using immunotherapy more and more for. In terms of thinking about using immunotherapies, first, it might be important just to appreciate how within the immune system, there are components that actually help the tumor. And there are also components of the immune system that actually fight the tumor. And so you can see with regards to these pro-tumor cells, there are cells such as specific flavors of macrophages and myeloid cells, as well as regulatory T cells that actually suppress immune responses and help cancer grow. On the other end of the spectrum, there are immune cells that actually fight cancer. And so these are different flavors of macrophages. As well as killer T cells and natural killer cells. And with immunotherapy, what we'd want to do is really try to balance towards those cells on the right, these killer cells, to recognize the cancer and be able to reject it. And so that's specifically what our immunotherapies try to do. With prostate cancer, we've been investigating some different approaches to treat the cancer with the immune system. And so those can be broken down into two classes of treatment. On the left, we can think about stimulating killer cells within a person. And on the right, we could actually think about, rather than stimulating these killer cells already in a patient, we could think about redirecting or reprogramming killer cells in that individual to recognize the prostate cancer. And so for the first example, this really requires a person to actually have immune cells that are actually able to recognize the cancer. And the cancer cells find ways to actually suppress an immune response, some of which we discussed previously. And so in this scenario, we can use antibodies that block inhibitors like these checkpoint inhibitors, anti-PD-1 and anti-CTLA-4 that have been so successful in many other cancers to recover that type of an immune response. The challenge has been that clinical trials just using this single approach have resulted in clinical responses in patients, but only in about 5 to 10% of patients. And so none of these approaches are currently FDA approved broadly for prostate cancer. They're only approved for specific types of prostate cancer that have DNA repair defects. Now, with regards to the second approach highlighted here, stimulating the killer cells, we can also think about cytokine therapies, which have, again, been around to treat other types of cancers for some time. These haven't gained very much traction in prostate cancer. And then the final example is actually vaccines. And this is where we actually have an FDA-approved cancer vaccine for prostate cancer called Sipuleucel-T or Provenge. And I'll talk a little bit more about that, but this is a immunotherapy that is FDA approved for men with castration-resistant prostate cancer. Now, moving to the right column, in terms of thinking about redirecting killer cells, this type of approach is useful when a person doesn't have T cells or immune cells that can recognize the cancer. And so in each of these cases, what we would do is we would actually redirect these killer cells within the patient, whereas they didn't recognize cancer before, but now actually change them so that they do recognize cancer. And so the two examples that I give, the first one is engineering killer T cells. And the prototype here is CAR, or chimeric antigen receptor T cells. This is an immunotherapy approach that has worked incredibly well for certain types of leukemias, lymphomas, as well as multiple myeloma. And there are currently clinical trials going on at UCSF that are studying these CAR T cells in cancer patients, but they're not FDA approved as of yet. These types of treatments are administered in clinical trials. The other example with regards to redirecting killer T cells is actually co-localizing, or pulling these killer cells into the tumor, so that by bringing them together, you can actually trigger these killer cells to target the cancer cells. And the prototype for this are what we call T cell engagers, or bispecifics. These are typically drugs that have one end of the drug that binds a protein on a cancer cell, and another part of the drug binds a protein on the immune cell. And so in doing so, they basically pull the immune cells into the tumor. And these are also in clinical trials and have also shown some clinical activity. But currently, these types of treatments are also only being administered in the context of clinical trials. So the FDA approved treatment that we have for prostate cancer is Sipuleucel-T, or Provenge. And what this treatment does is function as a cancer vaccine. And so what happens is cells from a patient get taken out through a process called a leukapheresis, shipped off to a company called Dendreon, and then they get manufactured into a vaccine comprised of that individual's own cells, but they're now loaded with a protein that's on the prostate cancers. And this is what educates the immune system to target that protein. And so those cells are given back to the same patient a couple of days later. And 3 of those treatments over the course of 5 to 6 weeks constitutes a treatment with regards to Sipuleucel-T. And so we know this treatment improves survival in patients with prostate cancer. The challenge has been that even though people can live longer receiving this treatment, we don't see tumor shrink or PSAs go down, one of these serum markers that we follow in prostate cancer. And so as a result, this treatment is typically given in individuals who are in a setting of castration-resistant disease, but where the cancer is not behaving aggressively. Now, we know that this treatment functions as a vaccine through different clinical trials. And this is one example where the patients received this Sipuleucel-T prior to surgery for prostate cancer. And when we took the tissues out in this clinical trial, we could actually see that those patients who received Sipuleucel-T had T cells, these killer cells, actually infiltrating their tumors. Those are the 2 panels on the left where you see that those big red spots that basically represent the T cells in the tumor. Whereas if you look at patients who haven't received Sipuleucel-T on the right, those actually do not have recruitment of the T cells that are there. And so this treatment functions as a vaccine. It primes immune cells to target the cancer, and those immune cells can actually then go to the tumors. Now, when we think about prostate cancer, there obviously are many other immunotherapies that have been studied in the clinic, and these have not gained traction in prostate cancer. And we're thinking primarily about the checkpoint inhibitors, the anti-PD-1 and anti-CTLA-4 antibodies. And why is that? Well, the challenge with prostate cancer is it has multiple ways in which the cancer has figured out how to defeat the immune system or turn the immune system off. And so this is a schematic of that, just showing, we want the killer T cells, which are these effector T cells in the middle, these orange cells. And they're basically faced with all these different other mechanisms that shut them down. We touched upon at the beginning of the talk the myeloid derived suppressor cells, or the MDSCs. These are that certain flavor of myeloid cell that can turn off these killer cells. We also talked about regulatory T cells that can also suppress these effector T cells and prevent them from functioning. But we can also think about other things that are released by the tumor microenvironment itself that basically can shut down these killer T cells. And these include different types of cytokines like TGF beta. They also include other immunosuppressive molecules and metabolites, such as adenosine, as highlighted here. And all of these conspire to shut down an immune response. And so, in thinking about immunotherapy for prostate cancer moving forward, we really need to think about not just delivering a single treatment, but how we might actually bring multiple treatments together to address all of these different immunosuppressive mechanisms simultaneously. And this is the goal of our research program, as well as other research programs around the world. And the important aspect is we're making progress. And as I highlighted earlier, we have different types of treatment modalities that are now eliciting clinical responses in the clinic. And we're hoping that those will evolve into treatments for prostate cancer in the future. And so with that, I'll wrap things up, and I look forward to your questions. Thank you.
Thank you so much, Dr. Fong, for that talk on prostate cancer immunotherapy. Like we've seen in other cancer types in our breakout sessions today, earlier today, and yesterday, there's a lot of progress happening, even in cancers like prostate cancer that traditionally haven't responded very well to checkpoint blockade immunotherapy, which has been proven effective in a number of cancer types, but not prostate. So it was wonderful to see kind of at the tail end of your presentation all the different targets that are available that are being studied now in clinical trials that help to shape that microenvironment, as you mentioned. In that, also toward the end, you spoke quite a bit about Sipuleucel-T, which is the only FDA-approved vaccine for prostate cancer, approved in 2010. So you mentioned also giving it prior to surgery, and this is something we heard about in the breast cancer session earlier today as well, something called the neoadjuvant setting. And so you're doing that with Sipuleucel-T. Is that something that we're also looking at with checkpoint blockade, which seems to be potentially or is effective in breast cancer?
Yeah, so thank you for that question, Brian. I think the key part of that study was really trying to understand how Sipuleucel-T works. Right now, there aren't clinical trials that are using it in a neoadjuvant fashion, but there is a completed clinical trial where we actually give Sipuleucel-T to men with prostate cancer, but are in what we call a watchful waiting phase. So actually, even before we think about definitive treatments like surgery or radiation therapy, and we're waiting for the results of that clinical trial to come out. And I think that really reflects this thought that using immunotherapies earlier and earlier will actually be more effective. In terms of thinking about checkpoint inhibition, we're actually doing exactly as you describe. We have a clinical trial giving checkpoint inhibition prior to surgical resection. And that clinical trial is currently open at UCSF. And in addition to seeing how patients do with that treatment, we're doing similar types of studies to really understand what type of killer cells or other immune cells get recruited into the tumor with checkpoint inhibition. And by teasing this all apart, we can think about ways to combine it together so that we can use all of these different modalities in a more coordinated fashion, as opposed to just trying to put them together and hoping for the best. And so that clinical trial is going on. And I'm hoping that will shed some light in terms of thinking about ways where we can actually improve the efficacy of checkpoint inhibition for prostate cancer.
Well, that's great. You answered one of the questions we had received prior to today's recording from one of our registrants about that watch and wait phase. I know that that's sometimes very uncomfortable for some patients. Others are happy that they know prostate cancer is very common, the most diagnosed cancer after skin cancer in men, and the leading cause of cancer deaths after lung cancer in men in the United States. So it is a disease that chances are good that you may encounter it at some point. If not you, then one of your buddies, friends, or family member. So really exciting to see that there's still a lot of research ongoing. Talk about that clinical trial, maybe as an example, for those of us, because we've also gotten a number of questions about trials and what is involved in those. We did have a session yesterday devoted to immunotherapy clinical trials. So if anyone hasn't seen that, it's available on demand, and we highly recommend that you check that out, as well as the basics of immunotherapy that we reviewed yesterday. But if a patient's on this trial that you're talking about, what is the day-to-day? How is the immunotherapy administered? How many tests and follow-up scans are required? Roughly.
Yeah, so for this neoadjuvant clinical trial, we don't want to delay the surgery. And so what that means is giving the immunotherapy, typically 1 or 2 treatments with an immunotherapy. And these are given every 3 weeks or so. And so the patient would need to come in, get a treatment, and if there's a second treatment that's part of the trial, they would come back again and get a second treatment. There would also be visits prior to starting the treatment. And for some of the arms, we actually do a biopsy of the prostate before we start the treatment. And then obviously at the time of surgery, the prostate is taken out. And the purpose of that is to see how things actually change over that period of time. And in terms of visits, we typically align those visits so that they happen at around the same time as when an individual would be also seeing their urologist, the person doing the surgery. And so we try to minimize the impact on folks who are participating on this trial. But it usually requires somewhere around 5 or 6 weeks lead time before the surgery to get the follow-up visits and procedures and visits in. But at our institution, oftentimes that is the typical lead time to get a surgery. And so it actually works out well.
What about prostate cancers that are more aggressive, where a patient is not in a watch and wait, but it's a 5-alarm, we have to take care of this now? Are clinical trials also options for that kind of patient?
Yeah, there are clinical trials that are focused on that. I think in this case, where we think about the 5-alarm with prostate cancer is prostate cancer that is actually spread outside the prostate gland. And so in that context, we have clinical trials also looking at using these checkpoint inhibitors like drugs that block PD-1. We also have studies that are combining them with certain types of treatment modalities, including vaccination, radiation therapy, which is commonly used, for prostate cancer. We're trying to use that as a way to also vaccinate a person to their own tumor. And there are other treatments that are combining with other types of prostate cancer treatments, including newer forms of hormonal therapies. There's actually a radioisotope that's targeted to prostate cancer that's called PSMA lutetium, that we have a trial combining that with checkpoint inhibition. So I think in these settings of more aggressive disease and in metastatic disease in particular, we actually have a broad range of clinical trials that are focused in that disease setting. The other thing to be aware about, as I alluded to in my talk, is we actually have other types of treatment modalities in the form of these bispecific antibodies as well as CAR T-cell therapies that are also in clinical trials. Now, those are typically for people where the conventional treatments for prostate cancer are no longer working. But as we understand how those treatments work and are able to manage these treatments, we're hoping that these treatments will actually migrate to earlier and earlier states of disease as well.
So a lot of options, it sounds like, are available for patients at different stages of their disease, which is wonderful. I'm sure that if I were a patient, I'd want to know that there is a next thing. What happens if a patient does try, let's say, a CAR T trial, and it doesn't seem to be working? Is he then eligible for another type of immunotherapy, perhaps, or another trial? How does that work?
Yeah, but potentially it depends actually case by case for the clinical trials and to what extent they allow individuals who have had those prior treatments. And so, it really would depend on the trials. I would say that receiving a CAR T cell will not eliminate treatment options for a patient, but it may reduce some of those options. And so it really would depend on a case by case basis.
And that's decided with the whole healthcare team, or patient discusses that. How is that decision made?
Yeah, that decision is made with the patient. We would review their history and see what treatments they have received, and then go through treatment options that would also include filtering out any trials, as an example, where those types of prior treatments would exclude them from participating on a trial. But that said, we, as you mentioned, we do have quite a few different trials going on for prostate cancer. And I think, this really reflects a lot of excitement in the field, but also our improved understanding of what's happening in prostate cancer, so that we're now moving forward in different directions than we had been in the past.
We've talked a lot about clinical trials, which is fantastic. And I'll just take this opportunity to remind those of you watching that Cancer Research Institute does have an immunotherapy clinical trial finder service available for free. At that service, you can be matched to clinical trials. You can get the assistance of a clinical trial navigator as well to help connect you with trials. Maybe you might have Dr. Fong as one of your physicians if you are in the San Francisco area. And Dr. Fong, these trials are available at multiple sites, I imagine, or there are trials everywhere for this.
That's right. These trials are happening across the country. Individual centers may actually have a different set of trials that they might offer. And so the service that you're offering is really so important and helpful, because sometimes it's information overload in terms of trying to understand what trials are going on and what trials are going on at a center near you. And, while we certainly have folks who travel from around the country to participate in some trials that we have, many of these trials can also be accessed through other institutions. And so, that really is a great service that you're providing.
Thank you. Here's another question from one of our registrants. Does age play a role in whether or not someone receives immunotherapy? And I guess this touches on the broader factors on what are all the factors that go into play that someone needs to be aware of.
Yeah, absolutely. There's a whole field called immunosenescence, where we know as people get older, our immune systems actually function less well. And unfortunately, it's one of those inherent processes, with aging. And, we know that as people get older, we get more susceptible to infections. And unfortunately, as we get older, our risks for dying from infection go up significantly. And I think this is actually a big challenge with regards to thinking about studying immunotherapy for prostate cancer because it tends to be a disease in older men, that we're dealing with an immune system that might not be functioning as well as it may have been in the past. And so, there are some studies, trying to think about ways where we can actually improve, the function of the immune system. We actually helped lead a clinical trial looking at a cytokine called IL-7 as an example, as a way to try to increase the number of lymphocytes in a person. But these are all still being studied in clinical trials, and I think is an important aspect of really trying to tailor the immunotherapy to an individual. And if a person is older with the cancer, what other additional types of treatment do we need to be thinking about in order to maximize our chances of that treatment actually working? And this is something that we're studying, but is really still in early days. But that's an incredibly important question, and something that we think about continually.
You mentioned also earlier other types of treatment that might be needed. And there were quite a few questions had come in about, such as, do I need to discontinue my hormone therapy, or I'm getting, this treatment. I'm interested in immunotherapy. It sounded to me that it's possible to continue receiving standard treatment as well as an investigational immunotherapy. Is that true? And what sort of examples can you give us?
Yeah, absolutely. So, with regards to prostate cancer, one of the mainstays of treatment is actually using hormonal therapy, as you describe. And what these hormonal therapies do is they suppress the body's production of testosterone. And these treatments, have been time tested and are effective against prostate cancer. And if a patient needs those treatments or has received those treatments, they typically stay on them while they're on the immunotherapies. And part of that is to make sure that there's this continued suppression on the prostate cancer. But the other component is we now know that male hormones, androgens, actually can compromise an immune response. And if you actually block those androgens, you can actually enhance immune responses. And so we're now actually really thinking about ways where we can coordinate the use of both of these treatment modalities for prostate cancer immunotherapy, hormonal therapy that we'd use anyway to treat prostate cancer, but really to think about ways we can combine those together in a more concerted effort to really improve outcomes with these immunotherapies.
Thank you for that. Lots of questions about combinations, so it's exciting. Another question is around side effects. We often get these. We know that the side effects of surgery and chemotherapy in treating prostate cancer are well described. What about immunotherapy? And is there anything we can learn about the potential outcome a patient might have if he's having a response like you're about to describe?
Yeah. So, unfortunately, with all cancer therapies, we can have side effects. With Sipuleucel T, those side effects are actually pretty minor. What I describe to my patients is really the inconvenience of the time it takes to harvest the cells and undergoing a leukapheresis. When patients get the cells, the side effects that they might experience include fevers or shakes when they're getting their cells back as their immune systems are being stimulated. But those are self-limited, they go away. And so there usually aren't long-standing risks of side effects. Now, with regards to our other immunotherapies, checkpoint inhibitors have risks of these immune-related toxicities that take the form of inflammation in different tissues in the body. They happen infrequently, but when they do happen, we need to manage those. And that includes using steroids or other ways to tamp down the immune response. With regards to the other therapies that I talked about, bispecifics and the CAR T cells, those also have significant risks of side effects, including this immune activation or what we call cytokine release syndrome. And when that happens, again, it's like your body's got a life threatening infection. And we give medicines to really try to, again, dampen the immune response. And those typically go away and resolve, but those can be life threatening. And so these are things that we in the team are always on the lookout for, and we want to intervene on those and manage those as soon as possible.
Well, thanks for that. Just a last question. Well, actually, two questions. My last one is around the response that patients have who are treated with immunotherapy. If the tumor, for instance, on scans doesn't appear to really be shrinking, but the patient feels better and the blood shows, or maybe there's a biopsy again that shows T cell infiltration, how long can a patient, is that the new norm? I know we know watch and wait, we talked about that, but is it the same thing with immunotherapy? Can someone's tumor remain but be stable?
Yeah, absolutely. And this is something that we think happens with Sipuleucel LT. The patients live longer, but their tumors don't necessarily shrink, or their PSA doesn't necessarily go down. And so I think there's a range of responses that we can potentially see. Some of them include tumors shrinking or PSAs going down. But what we can also see is the cancer being held in check by the immune system, where it's no longer progressing. And, from our perspective, especially for men who have advanced cancer, if we can hold the cancer in check, that in and of itself is also benefit. And so we look for these different types of outcomes in the clinical trials. And while we're all hoping for those tumors shrinking or disappearing, so long as they're not progressing, we think that the immunotherapies may be contributing to that. And that's something that we do look for in our clinical trials.
Good to know. Good to know that that's a potential outcome. And finally, my last question: knowing how far the field has come, what words would you give to a patient or caregiver who's encountering this diagnosis for the very first time?
Well, prostate cancer really can come in many flavors. Some that behave more aggressively, some that are behaving indolently. And I think, part of this is understanding where a person falls along that continuum and really thinking about tailoring treatment in terms of how the cancer is behaving. I think another important issue is really thinking about what your options are. Because with prostate cancer, we have a lot of treatments and we have a lot of treatment options. And I think, the important part is to know what your options are and then to select what is the best option for you. And for some, that might mean going on to a clinical trial. For some, that might mean using some of the standard of care treatments. And more than likely, people will actually do both over time. And it's really thinking about ways in which, these could be potentially complementary. And so this would be something that would be critical to discuss with your physician and, to again, vet the different options that are out there. It can be daunting, but this is where your physician, as well as resources like the CRI provides, hopefully will help guide you in terms of determining what those options are and how you want to proceed.
Well, thank you, Dr. Larry Fong, for that very insightful look at immunotherapy for prostate cancer. It is, I've said exciting multiple times. It truly is, given just the prevalence of this cancer among men. And also great to see all the progress happening in other cancers. This is our final breakout session for the day. So I'd like to thank everyone who attended and watched, and hopefully you caught some of our other sessions. Again, a reminder that we do have all of these sessions available on demand, becoming available shortly in the weeks to come, and you can share those and watch them as you see fit. Dr. Fong, once again, Thank you so much from the University of California, San Francisco. Keep up the great work, and we look forward to more developments in prostate cancer immunotherapy.
Terrific. Thank you for having me.